Take it away.
Awesome. Great. Thank you so much. Really happy to be here. As Adam said, my name is Trevor Thompson, currently at the Oregon Health and Science University. Recently graduated fellow from Cincinnati Children's Hospital. So wanted to begin with a couple of thanks. Again, first of all, to Adam and the ASPNR for the opportunity to talk, as well as a big thank you to my friends, colleagues, and mentors at Cincinnati Children's Hospital. I see Dr. Cook on the participant list here, so I appreciate that she's here, and hopefully I can make her proud as a past fellow. So this topic is one that I actually became interested in as a fellow because I felt, as Adam had mentioned, that this is can be a complicated topic. A lot of the diagnoses require some attention to very small details, and given kind of the overlap in the published literature, some of the terms kind of used interchangeably. I wanted to kind of make this for myself as well as a kind of a teaching tool for other folks that may kind of feel the same way, that this can be a kind of a quagmire of different things. So to begin with, I'm going to touch on some very general imaging considerations when it comes to abnormalities of the inner ear. We'll go over very briefly some relevant embryology and imaging anatomy, not going over the full gamut of temporal bone and inner ear stuff, but only the stuff that really needs to apply to the discussion today. Then we'll go through the algorithmic approach that I had developed kind of as a framework for myself and narrowing down these differentials. We'll wrap up with a few example cases to kind of see exactly how it works in practice, and then wrap up with a few key points at the end. So to begin with, general considerations when it comes to congenital sensorineural hearing loss and why it's important that this be diagnosed and addressed early. As we know, as kids grow and are learning their initial language skills, hearing is a big part of that. So listening to their parents talk, their friends talk, people around them is a big part of developing their language skills. And so if they're not able to hear them clearly or not able to hear them at all, obviously that can severely hamper their language development. And that kind of puts a hold on everything down the road when it comes to academic performance or socio-emotional skills. So this is an important thing to detect early and treat early if possible. Sensorineural hearing loss itself can result from abnormalities of either the inner ear structures, collectively termed the labyrinth, or the cochlear nerve itself as the transmission conduit from the inner ear structures to the brain. Up to half of cases of congenital sensorineural hearing loss will have a genetic cause, and of the acquired causes, post-infectious, primarily related to CMV infection, are going to be the most common. This graphic here on the right illustrates generally the components of a cochlear implant, which is going to be one of the mainstays of treatment, and we'll go into that detail here. Generally speaking, cochlear implant is going to be the primary treatment method for moderate to profound congenital sensorineural hearing loss. But there are some things that need to be present in order for the cochlear implant to be applicable. And that is related to how the device is designed. So when it comes to cochlear implants, there are two components. There's an external component, a part that just sits on the patient's head or ear. And those can be a couple of different flavors. On the one on the top here, it has kind of a separate microphone and speech processor that then goes to a transmitter. On the bottom image here, this is a kind of a combined device altogether. And what that does is it transmits the sound that is external to the patient's head and communicates that with the implanted portion of the device. So there's a receiver and stimulator that's going to be implanted deep to the soft tissues, but outside of the skull. And then an electrode gets threaded from that receiver stimulator through the bone and the middle ear into the cochlea. And so ideally what you're looking for is the electrode wrapping in the cochlea and making contact with the sensory apparatus in the cochlea that is then going to transmit the electrical signals from the electrode through the cochlear nerve to the brain and be interpreted as sound and understandable to the patient. Usually these cochlear implant electrodes are going to be put through the round window, or sometimes they'll make a small surgical opening near the round window that's termed a cochleostomy. In order for this to work properly, obviously we need a few things to be present. We need a cochlea or some semblance of a cochlea where they can place this electrode. We need to have a target for the electrostimulation. Usually that's going to be the modality and the organ of Corti within the cochlea that will allow that signal to be transmitted to the cochlear nerve, which then goes to the brain. So if any of these components is lacking, then cochlear implantation is not going to be possible or functional. And in that case, the next step would be an auditory brainstem implant. We're not going to go into detail on that particular topic today. It's going to be focused mostly on cochlear implantation. So in terms of imaging in these patients, oftentimes they're going to get a combination of both CT and MRI. The reason for that is that these two imaging modalities are very complementary to one another in terms of determining, first of all, the candidacy for cochlear implantation, help to select an appropriate length or size of a cochlear implant electrode, as well as detect any potential surgical hazards. So on this example here, this was a patient with bilateral cochlear aplasia, and we'll go into the details of that subsequently. But you can see that we we don't have a cochlear present, so we do not have a target for electrode placement. This patient would, because of that, not be a candidate for cochlear implantation. We can also see here that if they were, then certain surgical hazards should be evaluated. In this case, there are these very large emissary veins extending posteriorly along the margin of the temporal bone here into the occipital calvarium. These ones are posterior enough that they shouldn't really interfere with any surgical approach if it was going to be performed. However, obviously, we could imagine if one of these were displaced a little more anteriorly, that could be a potential problem. When it comes to CT and MRI, as in most things in the body, CT is going to give us a much better look at the bony structures. So it'll give us a great look at the osseous labyrinth with its improved spatial resolution. We can also evaluate the course of the facial nerve canal and whether that's going to be an issue for surgery. Look at the middle ear structures, including the ossicles, as well as the size of the internal auditory canal. Generally, CT is going to be accomplished with volumetric submillimeter reconstructions. And we have a couple of special oblique planes called the Stenver and Paschal views, which we'll touch on a little bit more in the anatomy portion of the talk. MRI, on the other hand, is going to give us a much better look at the fluid-filled structures within the inner ear, which is termed the membranous labyrinth, as opposed to the osseous labyrinth is what we're evaluating with CT. This is also going to be the workhorse for evaluation of cranial nerves, both in the internal auditory canal, as well as the cisterns surrounding the brainstem. And then we'll also get a good view of at least portions of the brain and brainstem on these dedicated studies. When it comes to MRI, one of the biggest sequences that we're going to be using is a heavily T2 weighted steady state GRE like Fiesta, Space, or CIS, depending on your manufacturer. And that is also going to include multiplanar reconstructions, including a particular oblique sagittal view along the IACs to look at those cranial nerves regarding presence of the nerves and size of the nerves. And we'll look at some examples of that again during the anatomy part. When it comes to classification of these inner ear abnormalities, the most agreed upon current classification was initially proposed by Jackler et al. In 1987 and was subsequently revised in 2017 by Sinaroglu and Bajin. And this is the terms that I'll be using in this talk, and again, generally kind of the most agreed upon ones in current practice. Interestingly, although we obviously need to do our due diligence in detecting abnormalities and characterizing those, the majority of patients that get sent for congenital sensory hearing loss will actually have normal inner ear structures, both on CT and MRI. So don't be alarmed if you do your best and look at everything and there's still not an abnormality to be found. Sometimes that's just the case. So very briefly touching on embryology. I wanted to draw a distinction here between the development of the inner ear structures on one hand and the development of the middle and external ear structures on the other, just to show that because they develop from different embryologic structures, abnormalities of one compartment may not translate to abnormalities in the other. So here, this is showing the early development of the inner ear structures, which initially begin from the otic placode, which is a thickening of the dorsal surface ectoderm, which subsequently forms an otic cup and eventually pinches off to form the otic vesicle, or the otocyst, which will go on to form the inner ear structures, which begins around the 3rd week of gestation and then progresses, depending on the component you're talking about, finalizing their formulation at between the 8th and the 22nd week. In contrast, the middle and external ear structures form from a combination of the first and second branchial apparatuses. And this slide isn't really to go through and review and remember all of the particular components, just to know that again, the inner ear structures and the middle and external ear form from different embryologic sources. And so while we may have very severe abnormalities of the inner ear or even complete non-formation of inner ear structures, the middle ear and external ear may be near normal or normal. So something to keep in mind. So now moving on to, again, a very brief review of imaging anatomy, not to go through all of the minutiae of temporal bone, but I did want to show a couple of representative slides to clarify anything, especially for any trainees that are watching. These are on the left some axial CT images, and on the right, these are going to be our heavily TT-weighted axial MRI images. And they show a lot of the same anatomy, but some strengths versus one versus the other. On the left here, we can see our nice coiled appearance of the cochlea with our 2.5 to 2 3/4 turns. These indentations along the outer or external contour of the cochlea are termed the interscalar septa. The cochlear promontory here, this bone that forms over the basal turn of the cochlea, is only present if the cochlea actually does form normally, and this is something that'll be absent if our cochlea does not form. We'll see that on some subsequent specific diagnoses. Moving to the bottom image here on the left, we can see where our cochlear nerve enters the base of the cochlea at the level of the cochlear aperture. And then the modiolus or modiolus, however you like your preferred pronunciation, is this bony core in the central portion of the cochlea. One thing that we can see on MRI that we cannot see on CT reliably is this thin septation that runs through the cochlear turns, and this is called the spiral lamina. On the MRI top right here, we can better see the nerves that are traversing the internal auditory canal, including the cochlear nerve here as it goes into the cochlear aperture. So the internal anatomy of the cochlea can be very confusing. Even for me now, I feel like I have trouble distinguishing or remembering the terminology of spiral lamina versus interscalar septa. And so this is something I definitely have to review myself, and something that can be confusing, again, when trainees are first learning this information as well. So I just wanted to take a second to go through this in a little more detail. So analogous to the images that we saw on the previous slide, we can see our bony core here in the modiolus. This is a cross-section through the cochlea. And we can see that our spiral lamina, as well as our interscalar septa, do both connect to the modiolus or modiolus centrally here. But the difference is that the spiral lamina bisects the cochlear turns, and this serves as a scaffolding to support the organ of Corti, which is that sensory structure that converts the mechanical energy that goes into the cochlea to the electrical signal that gets propagated through the cochlear nerve. The spiral lamina, however, doesn't contribute to the external contour of the cochlea itself. However, the interscalar septa does. And so all of these little lobulations or the little kind of clefts you have between your cochlear turns are due to the interscalar septa as they extend from the outside to the inside of the cochlea. And the terminology is important on some of the subsequent diagnoses that we'll talk about, where it comes down to differences in this kind of small microstructure of the cochlea and what's present and what's not. So moving on to, again, another slide highlighting a couple of differences in terminology. And this is something that's important when it comes to the understanding of what we're actually imaging on CT versus MRI. And this is looking at things outside of the cochlea primarily. On this axial CT images here, you can see we're a slightly different level than we were at the cochlea before. And here we get a better view of our internal auditory canal, our labyrinthine segment of our facial nerve coming off anteriorly into the region of the geniculate ganglion. And then we have our vestibule posterolaterally with our horizontally oriented, appropriately horizontal semicircular canal. a cross-section through our posterior semicircular canal and our normally sized, very thin vestibular aqueduct here. When it comes to MRI, we're actually imaging the fluid-filled structures within the bony labyrinth. And so when I'm talking to trainees about this, oftentimes I'll describe the bony labyrinth or the otic capsule as kind of the shell of the snail, if you will. And then the fluid-filled structures on the inside that we see on MRI are the kind of the squishy or soft parts of the snail. And there are actually two separate disparate compartments within the inner ear structures. The innermost component, which is filled by endolymph, includes in the vestibule, the utricle and saccule. In the semicircular canals, the semicircular ducts fill those, and then in the cochlear duct fills that. And that's on this diagram here on the right, the very kind of dark blue structures would be the areas of endolymph. And then between the endolymph-filled structures and the outer kind of bony shell, if you will, of the otic capsule is the perilymph. And that contacts the oval window and the round window as the kind of the junction between the middle and the inner ear. And this is the reason why if you have injury to one of those structures, or for example, in temporal bone trauma, you can get a perilymphatic fistula because it communicates with this perilymph-filled portion of the inner ear. And then finally, the vestibular aqueduct, that is the term we would use, obviously, for the finding on CT, where, as on MRI, we're actually visualizing the duct within that, which is the endolymphatic duct, and then on the very posterior edge, the endolymphatic sac. So just a very brief mention of our one most important, I would say, special view that we see on CT here, which would be the partial reconstruction. The way that our technologists perform this is to first align an oblique coronal plane through the posterior semicircular canal, indicated here by the yellow, along the long axis or longitudinally along the petrous ridge. Then we take a 90-degree perpendicular slice to that, and that forms our partial view. And the reason why this one is so nice is because, one, it lays out our semicircular canal very nicely here, and we can get a good look at that bony covering on top if we were looking for a case of dehiscence. We also can get an excellent view generally on one slice or maybe two adjacent slices of our round window and oval window. And then it also very nicely lays out our vestibular aqueduct, which will become important in terms of caliber as we talk about some of the specific diagnoses later in the talk. And then our one special oblique view that we'll look at on MRI is this slice here going cross-sectional through one of our internal auditory canals. And this is the classic mnemonic of facial nerve up and cochlear nerve down, 7 up, coch down. Of course, that's only a part of the story. You do have to remember which one is anterior and posterior. And thankfully, we know that the cochlea and the facial nerve canal extend anterior from the IAC, so those nerves should be anterior, whereas the vestibular components in the inner ear, the vestibule and semicircular canals are posterior, and that's where we're going to have our superior and inferior vestibular nerve divisions. Oftentimes, the vestibular nerve will appear kind of conjoined like this. We may not exactly see the distinction between the two components, and so it may look like a concerned sideways smiley face here instead of a nice four-quadrant nerve. But this is what a normal IAC content should look like. End of note, our facial nerve and cochlear nerve should be relatively similar caliber, whereas our vestibular nerves posteriorly can be slightly smaller in size, as we see here. So now that we got all the dry background out of the way, now we'll go into the algorithm here. This is what I had kind of initially put together based on the literature review. And I found it to be the kind of the easiest way to get to the final diagnosis. This relies on 5 usually fairly easy to answer questions. And as we kind of go through, it'll put you, if not to an exact diagnosis, then very near the ballpark of what you're looking for. And this does look a little complicated at first blush, but we will go through it in detail and hopefully make this very straightforward. So to begin with, the first question that we ask is, when it comes to the labyrinthine structures, first of all, are they present at all? And if they are present, Is it just a small cyst that doesn't communicate with the IAC, or is it more than that? So we are going to start with the most severe form of congenital abnormality where the inner ear structures do not form at all, and that's referred to as complete labyrinthine aplasia. You may also see this described as Meckel aplasia or Meckel deformity. This is very rare. As you can see, there are about 1% of all inner ear abnormalities. Generally, it's going to be a very early arrest in development before the 3rd week of gestational age. There's both environmental exposure tied to this in the form of thalidomide as well as some genetic causes. Generally, the imaging appearance is going to be, as the name implies, complete absence of any labyrinthine structures. So we will still see our very sclerotic portion of the temporal bone where the inner ear structure should be indicated by our green arrow there, but we will not see any formation of normal inner ear structures. Because of that, our cochlear promontory, usually, a nice hump-shaped part of bone there over the basal turn of the cochlea, is going to be flat, as in this case. And this can be helpful in distinguishing complete labyrinthine aplasia from the potential possibility of a very severe labyrinthitis ossificans, where the inner ear structures may have formed normally and then subsequently completely ossified. But in that case, you should still have a cochlear promontory because the cochlea did at some point form normally. Again, as I mentioned with the embryology, even though there's complete absence of the inner ear structures, the middle and external ear may still be completely normal. However, you can have some dysplastic portion of the stapes at that junction with the inner ear. Again, the junction between the inner and middle ears being abnormal, the oval and round windows could also be atretic for that reason. Generally speaking, we're only going to have the single facial nerve in that internal auditory canal, and so our canal is going to be very small and aberrant in course. We can see that a little bit better here on this different case, but same diagnosis on the patient's right side, where the IAC is very, very small. We can only see just the opening to it there indicated by the blue arrow, and only the facial nerve extending into it indicated there by the pink arrow on the top image. This case is also here to remind us that we need to evaluate each side independently. Just because one side is abnormal doesn't mean the other side will be, and just because one side has a given abnormality, the other side may have a different abnormality. So this is a case of right-sided complete labyrinthine aplasia and left-sided common cavity deformity, which we'll talk about subsequently. When it comes to complete labyrinthine aplasia, treatment is going to be, if anything, auditory brainstem implantation, because they obviously don't have a cochlea or a cochlear nerve that's going to allow cochlear implantation to be successful. So moving on to the other option, in the kind of the severe end of the spectrum here would be if we do have some inner ear structures, but all we see is a small cyst, potentially with some dysmorphic semicircular canals, but no communication to the internal auditory canal. And this is referred to as a rudimentary otis cyst, also very rare. The time of arrest is very similar to complete labyrinthine aplasia. It just maybe gets slightly further down the road. And similar to complete labyrinthine aplasia, the IAC is going to be atretic and again only contain the facial nerve. The big differential in this case is to not confuse it with the more common diagnosis of common cavity deformity. In that case, the cystic cavity will communicate with the IAC and is generally going to be significantly larger than these small otocysts. And similar to complete labyrinthine aplasia, treatment is going to be auditory brainstem implantation, as cochlear implantation is not going to be a possibility. So moving now further down the algorithm here, our first question regarding the presence of labyrinthine structures. Now we do have some present. It's more than just a small cyst. And whatever we do see is in communication with the IAC. The next question we have to ask is, can we reasonably separate a cochlea and a vestibule, or are they combined? And if we cannot separate them into different structures, then we need to look at the positioning of the IAC with respect to what's developed in the inner ear to determine if we're talking about cochlear aplasia or common cavity deformity. So cochlear aplasia, as the name is accurately describes, is a non-formation of the cochlea. However, the remainder of the inner ear structures are formed. This is a slightly later arrest than the stuff we had previously talked about around the 3rd week of gestational age. It's a little more common, but still rare at around 3% of all malformations. The IAC, because there is still deficiency of the cochlear nerve, is going to remain small. And on this example here, the top right image, this is our sagittal fiesta sliced through the IAC, and we can see in the anterior portion of the canal, there is one clearly defined nerve, and in the posterior part of the canal, there's a smaller nerve. Clearly, we're missing some here. Presumably, given the absence of the cochlea, this is the anterior nerve is the facial nerve, and the posterior is a component of the vestibular. Just a brief note on terminology for cochlear nerve, whether we want to use terms like absent or deficient. Generally speaking, the term deficient cochlear nerve is going to be preferred by the surgeons if we don't see it. The reason for that is in certain cases where the patients would otherwise be candidates for cochlear implantation, even if we may not see a cochlear nerve, if we report it as completely absent, that may tie the surgeon's hands in terms of what they're able to offer. Whereas if it's merely deficient, there may be some small nerve fibers that we're unable to see. Sometimes nerve fibers run along the facial nerve and can still get into the cochlea if it's present. And these patients may still then benefit from cochlear implantation. So, in generally speaking, deficient cochlear nerve is preferred as opposed to absent cochlear nerve. Or you could just be descriptive and say that it is not visualized. That's perfectly fine as well. Looking at the vestibular system in patients with cochlear aplasia, oftentimes this is going to be abnormal as well. Here we can see the most common associated morphology, which is a globular distension of the vestibule and the adjacent horizontal semicircular canal, which is abbreviated by the acronym GVHSA. In this case, the position of the IAC is going to help us distinguish between cochlear aplasia and common cavity deformity, which is the next thing that we'll talk about. In cochlear aplasia, because the cochlea normally would form anterior to your internal auditory canal, the internal auditory canal here is going to be positioned along the anterior margin of your formed inner ear structures, and you're going to have no inner ear structures anterior to your internal auditory canal. In common cavity deformity, in contrast, the IAC is going to extend into the more or less central portion of the developed inner ear structures, and we'll see an example of that next. Here, because there's no cochlea and the cochlear nerve is deficient, these patients also are not going to be candidates for cochlear implantation. So now moving on to common cavity deformity, this is significantly more common than the things we had already talked about, around 25% of all inner ear malformations. And in contrast to our prior case, we can see here now that we do have a component of our inner ear structures forming anterior to our internal auditory canal, but we don't have a clearly distinguished cochlea from vestibule. We can kind of imply that this is probably the kind of cochlear modality here, and this is the vestibular modality posteriorly, but it's not very well defined, and that's what typifies common cavity deformity. Oftentimes in the setting of common cavity deformity, there's going to be very wide communication between your IAC and the cystic inner ear structures, which can be a risk for CSF leak at the time of surgery. Cochlear nerve is often going to be small, but is typically present. And again, this is where the term deficient cochlear nerve is more useful for the surgeons than absent cochlear nerve. And there has been a described genetic association with HOXA1 gene mutations. Because there is a target for the cochlear implant, potentially nerve fibers present, these patients are candidates for cochlear implantation. And generally, because there's not a nice coiled appearance of the cochlea, in order to place the electrode, the surgeons will try to layer this more along the periphery of the cavity, which is where the sensory apparatus tends to end up. On this example here on the right, we can see some of those typical findings where we have again, a common cavity, a single cavity within the inner ear that composes the cochlea and vestibular components. And our IAC here is extending more or less into the central portion of the cystic structure. This patient also happened to have Charge syndrome, and so we had another couple of nice examples of the 4 Cs that we see in the head and neck with Charge, which includes abnormalities of the cochlea and the semicircular canals that we already discussed, but also choanal atresia and coloboma. So never stop looking for other abnormalities. So moving further down the algorithm here now, we're getting to where things are looking more normal overall. We do have a separate cochlea and vestibule, and we now need to look at the cochlear size. With a smaller short cochlea typifying cochlear hypoplasia, which is the spectrum of findings that we will discuss here. So the common theme with cochlear hypoplasia is that the cochlea is either too small or it is truncated, so it's lacking the normal 2.5 turns. And the morphology of the cochlea and presence or absence of internal structures is what's going to help distinguish the different forms of cochlear hypoplasia. Type 1 cochlear hypoplasia, indicated here on this top left image by the pink arrows, is what's referred to as a bud-like cochlea. So we have just a very small malformed cochlea with, again, kind of only a single bud-like appearance rather than any discrete cochlear turns. Type 2 cochlea is going to be a little bit larger, but still overall too small. There may be some slight external lobulations, as in this case here, but the internal structures in the form of the modality is going to be either very hypoplastic or absent. And you can see here we have a very widened cochlear aperture, which increases risk for CSF leak there. Type 3 cochlear hypoplasia is going to be a truncation. So if you think of the kind of stack of cochlear turns as a short stack of pancakes, this here is you're missing a few pancakes on the top. The basal turn looks relatively normal, but you don't have the normal mid and apical turns as indicated there by the green arrow. And finally, type 4 cochlear hypoplasia is a overall small cochlea with a relatively normal number of turns. However, you can see it has a very characteristic unwound appearance. And so continuing the thread of baked goods, this would be your cinnamon roll if you were to start unrolling the cinnamon roll. And your access now through the center of your cochlea is no longer through the center of your basal turn. This appearance this unwound appearance can also be seen in the setting of brachio-otorenal syndrome. And in that case, we would be looking for associated enlarged eustachian tubes to imply that diagnosis. The vestibule and semicircular canals being the other components of the inner ear may or may not be normal or slightly malformed. And typically, there is going to be cochlear nerve deficiency associated with this and a narrow internal auditory canal that we can see on that top right image indicated by the red arrow. These patients' treatment is going to be relatively controversial still. Some surgeons will still attempt cochlear implantation depending on how much of the cochlea is formed, and others will not. So moving on to our final section here, the last group of diagnoses. This is getting to where, at first blush, looking through these studies, things may look pretty normal overall. And it's going to be very close attention to the cochlea itself that's going to really help us nail down one of these. So this all boils down to the internal cochlear architecture and whether we have at least partial presence of the modality in the internal structures, complete absence, or a characteristic corkscrew appearance of the cochlea, which we will see a sex example here. So to begin with, incomplete partition type 1 is going to be a complete absence of the internal cochlear structure. So we can see in the diagrammatic view here at the top, we have a cochlear present, which is overall normal in size, so not in the cochlear hypoplasia spectrum. We have some gentle lobulations, but we have no modality. We have, by definition, then no interscalar septa present. We may have some partial spiral lamina, but not much. And when it comes to incomplete partition type 1, severity can range from mild to severe in the most mild forms. Again, we may have a look more like this diagram here. In the most severe forms, you're also going to get abnormalities of your vestibule and semicircular canal, which has been characteristically described as a figure 8 appearance and termed cystic cochlear vestibular malformation. And we can imagine here putting these two axial slices together where we have this dilated kind of amorphous cochlea without an internal structure, and then this associated dilated vestibule and how this could form a figure of 8. Interestingly, these patients will also often have a very wide communication with your internal auditory canal, which can, again, increase risk of CSF leak at the time of surgery. Moving on to incomplete partition type 2, these are the patients that make me nervous if I'm going through quick. As kind of first glance, these may come across as looking very normal overall. We have a relatively normal looking cochlea that's normal in size. We have at least a portion of the modality present at the base and the interscalar septa present. And however, here we have an absence of the internal structures towards the apex of the cochlea, indicated here by the pink arrow. In this particular case, there are some associated abnormalities that go along with this, which includes a enlarged and kind of dysmorphic vestibule, as well as a enlarged vestibular aqueduct. And the combination of the three things, IP type 2, enlarged vestibule, and enlarged vestibular aqueduct, is going to be comprising the classic Mondini deformity as it was originally described. This can get a little confusing, and a lot of times the term Mondini deformity is used kind of more ambiguously in the published literature. And so sometimes folks will lump all of the incomplete partition types as Mondini spectrum or something along those lines. But it is classically described as these three findings together being the Mondini deformity. The IAC, cochlear aperture, and facial nerve canals are often going to be normal. So again, these patients can sometimes try to sneak through as overall normal if we're not paying very close attention to the internal architecture of the cochlea. There are some genetic causes, both syndromic associated with Pendred, as well as non-syndromic genetic malformations. And then the treatment in these patients is going to be cochlear implantation. So moving on to our last incomplete partition type, this is type 3. This has been historically described as X-linked Stapes gusher, or alternatively X-linked deafness type 3 with Stapes fixation, if you like longer terms. This is, as the name implies, an X-linked inherited disorder related to mutation of the POU3F4 gene, and is characterized by complete absence of the modality similar to type 1. However, we have more of a presence of these interscalar septa as they extend from the outside to the inside of the cochlea. And so what results is this very characteristic corkscrew cochlear morphology. This can also be variably described as a Christmas tree or a pine cone appearance of the cochlea, which I think is also very appropriate, especially on this MRI. These look like those Christmas tree cookies you get around the holidays, or as my kids like to pick up all the time, pine cones. There's often going to be a wide communication, again, between your IAC and your cochlea via a wide cochlear aperture. And this is where the portion of the name comes from, the Stapes, the X-linked gusher, and that's because these are the cases that the surgeons, when they get into placing the cochlear implants, will get a very large gush of CSF, and there can actually be quite a high volume of CSF lost with these particular malformations when they're doing their surgeries. There's oftentimes some subtle associated abnormalities of the vestibule semicircular canal, but they're non-specific, and other times these other inner structures can be completely normal. So to wrap up, things that didn't fit nicely in the algorithm, a couple of isolated things, which are enlarged vestibular aqueduct and then isolated cochlear nerve deficiency. So enlarged vestibular aqueduct, as the name implies, is enlargement of the vestibular aqueduct. It makes sense. It is going to be the most common abnormality that we encounter when imaging for sensorineural hearing loss, and may or may not be associated with other inner ear abnormalities. We saw an example previously where it was associated with incomplete partition type 2 in Mondini deformity. Oftentimes it's going to be bilateral, but it may not be the same severity as in this case on the right side versus the left side. We can see that left vestibular aqueduct is clearly dilated compared to the right, which is only slightly dilated. Clinically, these patients are going to classically present with a stepwise progression of hearing loss with mild trauma, and so oftentimes they're instructed to avoid contact sports. There are various published diagnostic criteria. The classic oldest criteria is the Valvasori, which is considered positive if the canal measures greater than 1.5 millimeters at the mid portion, indicated here the level of these pink arrows. The Cincinnati criteria was subsequently published and is more sensitive. That cutoff is 1 millimeter at the mid portion on axial images or 2 millimeters at the operculum on axial images. Because measuring the operculum width can get a little complicated depending on the orientation and the angulation of the canal, I prefer to use this other measurement method, which is referred to as the midpoint partial diameter. And that is considered enlarged if it measures greater than 0.8 millimeters at the mid portion. And a lot of times, if your partial views are oriented correctly, you can get the entire vestibular aqueduct in 1 or 2 slices, and this gives you a very nice reproducible way of measuring these things. If you want to rather use a subjective measure as opposed to objective measure, just going through quickly, which I definitely do. If I don't have any other concerns, then you can use the posterior semicircular canal as an internal control. And if your vestibular aqueduct is smaller in caliber than that posterior semicircular canal, then it's normal. Once it starts approaching that size or getting larger, then we need to start measuring it. So moving on now to isolated cochlear nerve deficiency. As the name implies, it's an isolated deficiency of the cochlear nerve with otherwise relatively normal inner ear structures. Because the cochlear nerve is deficient, oftentimes the internal auditory canal is going to be somewhat small. We can see this example here. This patient that had left-sided cochlear nerve deficiency where the internal auditory canal is asymmetrically slightly smaller than the normal right side. On the right, when we do our oblique reconstructions through the IAC, we see our nice smiley face here with appropriately sized nerves. On the left side, however, we see, unfortunately, not able to clearly distinguish the facial nerve and the vestibular component posteriorly, but there's clearly a deficiency or a very small size of that cochlear nerve in the anterior inferior aspect of the IAC. On this companion case here, we can see that the IAC is relatively normal in size. However, the cochlear aperture is very small, and that is because there is a deficiency of the cochlear nerve. Here we don't see any residual nerve in the canal. Again, this would ideally be referred to as cochlear nerve deficiency rather than absence of the cochlear nerve. These patients still often benefit from cochlear implantation, and that's going to depend on the surgeon and the functional testing. So moving on now to wrap things up, just a couple of illustrated cases to go through the kind of the algorithm, show how it works, getting to the final diagnosis. So here are some select axial, heavily T2-weighted MRI images on the left, showing the abnormal right side in contrast to the normal left side, which is included for comparison. We can see here that our internal auditory canal extends along the anterior margin of this cystic structure in the right inner ear. We don't see anything developed anteriorly to that. This presumably is the dysplastic vestibule, which is enlarged, and then the component of the horizontal semicircular canal we can see adjacent to it also appears to be dysplastic and enlarged. When we're doing our oblique reconstructions through the internal auditory, we see just a single nerve there, whereas on the left we can see our normal nerve bundles. And so this would be, according to our algorithm, diagnosed as cochlear aplasia, in this case with an associated globular vestibule and horizontal semicircular canal anomaly. Here's another example. This one, again, looking overall much more normal than the prior case, but still does have some subtle abnormalities. On the top axial CT images, we can see that our cochlea is present. Our vestibule is present, as are our semicircular canals. IAC looks to be relatively normal caliber from what we can see here, and as is our cochlear aperture. When we're looking at the internal structure of the cochlea, we can see the modality here present at the base. But as we move towards the apex of the cochlea, the middle and apical turns, we no longer see that modality, and our external contours become a little blunted here. In conjunction with that, we have some subtle enlargement of the vestibule And on our postural views, we can see clearly that there's dilation of the vestibular aqueduct. So the combination here of incomplete partition type 2 with a dilated vestibule and enlarged vestibular aqueduct again characterizes the classic Mondini deformity. And this patient would be a candidate for cochlear implantation. So to wrap up, a summary of the key points that we covered today. The majority of patients with congenital sensory hearing loss are interestingly going to have normal imaging. If we do see abnormalities, then enlarged vestibular aqueduct is going to be probably the most common thing that we see. The inner ear and the middle ear and external ear have different embryologic origins. So just because the inner ear may be completely malformed, the middle and external ear may be normal or near normal. Cochlear implantation is overall a treatment of choice for moderate to profound sensory hearing loss, but they do need to have the appropriate structures present in order to make that work properly. Complete absence of the labyrinthine structures characterizes a labyrinthine aplasia. When we're trying to distinguish between cochlear aplasia and common cavity deformity, remember to look at that positioning of your IAC. Incomplete partition is going to be characterized by either complete or partial absence of the internal cochlear architecture. And remember that combination of the three things leading to the classic Mondini deformity. Finally, X-linked stapes gusher or incomplete partition type 3 has the characteristic corkscrew cochlea and has a very high risk of associated CSF leak, as does common cavity deformity and complete partition type 1. So these are things that we could highlight to our surgeons to make them aware of that before they get into trouble. Finally, a spectrum of findings in cochlear aplasia is going to be either a small sized cochlea or a short cochlea lacking the normal requisite number of turns. And in large vestibular aqueduct, we discussed the diagnostic criteria for that. And that may be the only finding that you see in the setting of sensorineural hearing loss. So with that, I will say thank you very much again for your opportunity to talk to you and for your attention, and definitely welcome any questions that anybody has.
Thank you so much. That was great. I mean, really helpful, kind of clear pathway, hopefully to make the correct diagnosis. It was wonderful. Yeah, if anybody has any questions or comments, feel free to throw it in the chat. So I was wondering, so do the techs routinely make the postural view? Do they make any other, they kind of send any other views, do any other 3D kind of reformations, or do you have to do any of those recons yourself?
Yeah, that's a great question. So ideally, yes, they generally should perform the postural reconstructions. I would say our typical protocol is axial and coronal plus the postural as the only special view. We don't routinely generate or send the Stenvers, although it's a portion of the reconstruction, as I described it. There are certain things we look for on that, but I don't find that view to be necessarily critical as are the other ones. And so if they're missing that one, I don't necessarily call and have them resend it. Only rarely do we have to do 3D reconstruction, and that is usually something that we would have to do at our own workstation to answer that question. That's not something that techs would send routinely. Yeah.
Okay, awesome. Okay, if you have any questions, throw it in the chat. Everybody's very clear on how to interpret these now.
Perfect. That's the goal. Yeah.
Yeah. Okay. If there's no questions or comments, then thank you so much for this awesome lecture. Hopefully see everybody else. See everybody next month, and thank you again, Dr. Thompson, for this wonderful talk.
Thank you. I appreciate it.
Well, take care.
You too.